Good afternoon, everyone. My name is Lisa Zimmerman. I'm from the Rehabilitation Research and Training Institute in Albany, New York. Thank you for joining us for today's webinar, Alzheimer's and Other Dementias, Functional and Behavioral Changes. These professional development webinars, which are presented in conjunction with RRTI and the Lewin Group for social workers, counselors, registered nurses, and other healthcare professionals, are supported through the Medicare-Medicaid Coordination Office, or MMCO, in the Centers for Medicare and Medicaid Services, or CMS, to ensure beneficiaries enrolled in Medicare and Medicaid have access to seamless, high-quality health care that includes the full range of covered services in both programs. To support providers in their efforts to deliver more integrated, coordinated care to Medicare Medicaid enrollees, MMCO is developing technical assistance and actionable tools based on successful innovations in care models, such as this webinar series. To learn more about current efforts and resources, please visit Resources for Integrated Care at www.resourcesforintegratedcare.com for more details. Just a little housekeeping before we get started. Your microphones will be muted throughout the presentation. However, there will be question and answer portions during this webinar, so if you do have a question, please click the Raise Hand feature on your control panel at the designated time, and you will be unmuted by an administrator. You can also type your questions into the chat window, and an administrator will ask the question out loud during that designated time. There will also be poll questions at the end of throughout the presentation. A window will appear with the questions, and you can submit your answers at that time. At the conclusion of the webinar, a tab will appear in your browser prompting you to complete the evaluation survey. It is required that you complete the evaluation survey in order to receive 3 contact hours each from the Michigan Social Work Continuing Education Collaborative, New Hampshire Nurses Association, National Board for Certified Counselors, and National Association of Social Workers. If you are unable to complete the survey at the end of the webinar, you will receive an email tomorrow with a link to complete the survey at that time if you have not already done so. So at this time, I'd like to introduce our instructors to you. Jill Dorsey is a licensed clinical social worker who has over 30 years experience working with individuals with mental illness and developmental disabilities, including individuals above age 60 in community-based family residences. She is also a trainer in person-centered planning, cultural competence, and recovery-focused practices. Linda Anderson is a registered nurse screener for HealthQuest Thompson House, where she meets and reviews patients in all area hospitals as potential rehab candidates in subacute rehab, and is PRI and screener certified. She was previously employed as a CMNH at Taconic DDSO for 20 years in the Family Care Unit and 15 years at Helen Hayes Hospital in acute rehab. Ms. Anderson is also a member of the Bereavement Committee at Taconic DDSO and a Prader-Willi educator, as well as a participant in IVR study on Fragile X and Down syndrome and Alzheimer's disease. Now we can begin.
Good afternoon, everyone. I'm Jill Dorsey, and I'm here with Linda Anderson. Linda and I worked together for a long time, about 10, 15 years, managing a caseload of about 200 people who were over 60 with intellectual and developmental disabilities and living in the homes of family caregivers. We brought a lot of interesting experiences to that time. And what was particularly interesting was that working together, I'm a social worker and Linda's a nurse, we were able to collaborate very effectively to provide person-centered and holistic care to the individuals that we were serving. In this module, we're going to be looking at some of the risks and manifestations of dementias in individuals with intellectual and developmental disabilities. And we're also going to be looking at the challenges that these people face, as well as their caregivers, in coping and understanding the process of dementia, which can be quite intimidating. I want to remind you that there are PDFs that were sent to you as part of this presentation. You can download them now, or you can also go to Resources for Integrated Care. The web address is at the bottom of each slide, and they'll be available there for your further information. So the learning objectives objectives for today's presentation are to identify the scope of physical and cognitive changes associated with the progression of dementia for people with intellectual disabilities, become familiar with the ways that Alzheimer's disease and other dementias affect individuals with IDDD, learn about early evaluation and assessment strategies for identifying and managing dementias to facilitate better support, identify syndrome-specific concerns for individuals with Down syndrome, and differentiate between behavioral changes that may signal the onset of dementia and those that may indicate other, often treatable, mental or physical conditions.
So what is an intellectual or developmental disability? An intellectual limitation that hinders independent functioning in daily activities such as self-care, communication, work, and education. It also developed before the age of 22 and is expected to continue. It results in a need for long-term adaptive and/or functional supports. Some people with developmental disabilities do not have an intellectual disability but face other challenges such as impaired mobility, seizures, and communication disorders.
So with intellectual and developmental disabilities, people experience deficits in their skills and cognitive abilities that may be underdeveloped or absent. So a person will learn to dress themselves, they may learn to choose clothes appropriate to the weather, they achieve goals in their community and become more independent in managing money, shopping for groceries, and so forth. They're going to grow and change, but their progress is going to be slow, but it's still measurable. Someone with dementia is going to begin to lose skills that he or she has already gained. So the person who used to be able to dress himself is going to forget how to use buttons, or is going to forget where a shirt goes, and try to put the shirt on instead of pants. They're going to become confused shopping. They're not going to be able to manage money anymore. Dementia is frequently irreversible, and it's progressive. It comes on gradually, so it's often very difficult to diagnose and recognize. The issue of dementia and people with intellectual disabilities is becoming a greater focus right now because people are living longer and experiencing many of the risks that are associated with Alzheimer's disease and other dementias. People with Down syndrome in particular have both an increased life expectancy and a much higher risk of developing dementia. 25% of people with Down syndrome will develop dementia after the age of 40, and after the age of 60, that goes up to between 50 and 70%. In addition to Alzheimer's, individuals experience a greater risk of developing other dementias, which we will be discussing as part of this presentation. So in response to the increasing number of individuals with intellectual and developmental disabilities who are living into old age, there have been numerous initiatives generated worldwide. Some of the issues that are being given special attention are supporting people with IDDD to sustain community integration using person-centered planning and the principles of self-determination. These are already very prevalent in that field, but primarily with people who are younger, young adults, and middle-aged adults. Developing protocols to improve accurate and early identification of dementia with people who have IDDD. We're going to be looking at how challenging it can be to assess somebody who has an intellectual disability using traditional or standard tests. There's some work being done on developing assessment and diagnostic protocols that are designed specifically for people with IDDD. And there are also some considerations for interventions and planning that will best support the best outcomes for people with IDDD as they age. So we'll begin by looking at what dementia is, the various causes of dementia, and who is at particular risk for dementia.
So what is dementia? It's a term that describes a generic process characterized by cognitive decline that impairs ability to function socially, personally, and productively, is persistent and progressive, and is associated with chronic brain disorder. It's a disease process, not part of the normal aging process. It may be caused by various factors such as strokes, head injuries, heart disease. It's important to know a differential diagnosis. Some dementias, such as NPH, normal pressure hydrocephalus, may be preventable and reversible, by shunting. Some with early diagnosis and treatment can slow the process.
So documenting a baseline is essential, and we're going to seem to be repeating this over and over again, but I don't think we can stress it enough, because working with someone who has an intellectual disability and begins to lose skills becomes very challenging to diagnose, because you don't know what skills they already had and what skills they're losing. So identifying dementia in people with IDDD is typically based on impairments in communication and daily functioning. That's also that's also the assessment tool for somebody who does not have an IDDD. But an individual with IDDD often has a lifelong history of impairments in these areas. The person may have a limited vocabulary. The person may need help with all the activities of daily living as a result of the developmental disability, not as a result of an emerging dementia. Standard assessment tools that are used to diagnose dementia are designed for people who do not have IDDD and are based on the person's history of being functionally independent in activities of daily living and communication. And again, these are the areas that are often where people with IDDD struggle the most. That's why a baseline is so extremely important in diagnosing dementia for someone with IDDD. Most researchers in the field recommend making a video recording of the person when they're functioning at their best, because it documents that person's abilities very comprehensively. And this video recording can be repeated regularly and shared among caregivers, particularly as caregivers change. They may not know what the person was like when he or she was functioning to the best of her ability.
So what are the groups at higher risk for developing Alzheimer's? People with Down syndrome, as Jill has mentioned several times, over the age of 35 to 40 are at higher risk. People with a history of Alzheimer's disease in their family. People who have suffered a head injury or a series of head injuries during their lifetimes. For example, people with seizure disorders or those who have experienced frequent falls. People with Down syndromes are living longer and so experiencing greater risk of developing a dementia. It's important to know those baselines, as Jill mentioned, to be proactive in getting a family history and sharing that with other health professionals. You should be contacting families if possible, if you can locate families of some of the people under your care to get family histories.
So there are a variety of different types of dementia, and treatment and outcomes are different depending on the type of dementia. They progress differently, the outcome is differently. Some may not be progressive. Some, like Alzheimer's, are progressive and cannot be reversed. The symptoms, functioning, and deficit and presentation of the progression vary very much on the type of dementia. And that's why a differential diagnosis is so important, because treatment, planning for the future care, and outcomes depend on the type of dementia that the person is experiencing.
There are many types of dementia, different causes, symptoms, progression. Treatment is determined by what type of dementia, as Jill said. This is a graphic that depicts the most common types of dementia, and we'll look at each of these in greater detail.
Okay, the most common form of dementia is Alzheimer's disease. The most common form of dementia is Alzheimer's disease, and that accounts for 60 to 80% of all dementias. It's the type that's most commonly discussed because it is so common, and it's characterized by a progressive loss of cognitive functioning. And this loss of abilities is not reversible. It's characterized by abnormal deposits of the protein beta amyloid, which forms plaques, which I guess are like little lumps, you were saying?
Yeah, like little spots.
Or tangles in the brain. And later on we're going to have a really interesting graphic that shows some of that protein deposits. People with Down syndrome are at particular risk for developing Alzheimer's disease. As we mentioned, between 50 and 70% of them develop it if they live after the age of 60. And again, it's a progressive and irreversible loss of cognitive functioning, and it's actually pretty tragic. Do you want to tell me about vascular dementia?
Vascular dementia is like multiple small strokes or changes in the brain's blood supply. Damage may occur anywhere in the brain. Knowing what part of the brain is damaged will impact what you're dealing with in the type of dementia. It affects the functioning and is variable depending on the location and the extent of damage. Diagnosis is complicated because vascular disease are a common feature of Alzheimer's disease. No treatment is available, although the cause of a stroke, such as high blood pressure, may be addressed to prevent future events. Many small strokes are not progressive, but they damage a portion of your brain, which will cause symptoms of dementia, or can cause symptoms of dementia. It can't be corrected what's damaged, but it can be prevented for further damage. So it's important to know what type of dementia you're dealing with if it's vascular.
So mixed dementia is actually a combination of Alzheimer's and vascular dementia. Because Alzheimer's compromises the way your veins function, you are much more prone to having a stroke. And in this case, as Linda was mentioning, you also need to have a differential diagnosis. Managing high blood pressure or other risk factors for strokes can help to minimize the progression, but it wouldn't stop the progression if the person has Alzheimer's. Right?
So, frontal temporal dementia involves damage to brain cells in the front and the side regions of the brain. And symptoms include personality and behavior changes and difficulties with communication, because that's what the frontal and the temporal lobes of the brain control. An example of this type of dementia is Pick's disease. It's characterized by the Pick's bodies in the frontal and temporal lobe. There is no distinguishing microscopic abnormality. It's eating away at your brain is what's happening with Pick's disease. It is not reversible. It's a very rapid progression compared to Alzheimer's, which is over a longer period of time. This could be within a period of months to have substantial damage. A person is losing their sense of self, wandering. They don't have the cognitive skills to make life decisions. Severe personality changes may be involved. Communication and hearing deficits may be involved because the speech and hearing centers are in the temporal region. It's a very flat affect the person would have. Wandering, like I said, is very common, and they require intensive oversight to ensure their safety.
So I imagine it would be really difficult to provide living arrangements, environmental support for someone with Pick's
disease. Yes, it's in a controlled environment, in a locked Alzheimer unit, because they can't. They don't know who they are or where they are any longer.
Another type of dementia is dementia with Lewy bodies. And this is an irreversible brain disease associated with protein deposits, and the protein deposits are called the Lewy bodies. And they appear in deteriorating nerve cells. This is very common with people who also have Parkinson's disease. The symptoms are extremely similar to Alzheimer's disease, and many times Lewy bodies dementia is misdiagnosed as Alzheimer's. However, there are some features that kind of distinguish it from Alzheimer's, mainly that cognitive functioning in dementia with Lewy bodies fluctuates. So on some days the person may be functioning quite well. They may, be able to dress themselves. They may be able to cook a meal for their family, and then the next day they no longer can do that. So it's very difficult for families to understand. It's very difficult for them to provide consistent supports. I think, Linda, you worked with someone who had Lewy body dementia, and her husband thought that she was doing really well, and he left her alone, and
she wandered out the door, and she ended up hit by a car.
So, when you're working with somebody who has this kind of dementia, and this is why the differential diagnosis is so important, you need to be aware of providing safeguards for that person consistently, because you never know where their cognitive functioning is going to be. Another part of this is visual hallucinations, and these people are also very sensitive to the use of psychotropic medications, so that's another oversight issue that needs to be considered when working with somebody.
The other thing is the fluctuating cognitive skills. Like one day they're able to do something, the next day they're not. It's very confusing to a family member. Like this particular person that I took care of, he would get very angry at his wife because he said, "What's wrong with you? You could do this yesterday. Why aren't you doing it today?" Like a simple thing like dress yourself. and he just didn't understand it was all related to the disease.
There's probably also a lot of denial with families, too, because they may have the diagnosis, and they may, on one level, understand that the person is struggling cognitively, and then they see them functioning well, and they think, well, maybe it's not really happening. Maybe the diagnosis was wrong.
Okay, normal pressure hydrocephalus, or NPH, is another type of dementia, but it is a type of dementia that, of course, early enough, the person could be shunted to move the fluid out of the, to stop the pressure on the brain. By a surgical installation of a shunt to drain that excess fluid can prevent the damage that would have occurred, and in essence preventing that type of dementia from progressing. So it is one of the dementias we see that can be repaired with an early diagnosis and prevented, unlike most dementias that you can slow down the process, but you're not actually stopping the process.
So now, if somebody has a shunt to address NPH, would they be able to live in the community? Is that hard to manage?
No, not at all. Okay, mild cognitive impairment is another type of dementia. It's a problem with memory and cognitive skills, severe enough to be noticeable, but not severe enough to interfere with daily life. Parkinson's disease is also a neurological disorder that may go on to develop into a dementia in later stages of the disease. Parkinson's disease may lead to a dementia as part of the later part of the disease, but the person may appear to be developing dementia, but this may actually be a side effect of medications being used to treat Parkinson's. So you need that differential diagnosis. Is it the meds? Is it the Parkinson's? What's going on with this person? Because some things you can resolve, some things you can't. As Jill had said, recent studies have indicated that the presence of Lewy bodies is often discovered in people with Parkinson's. MCI is not part of the normal aging process. It is a condition that is an early dementia. It's a mild cognitive impairment that still needs to be monitored, evaluated, and managed.
And that may not lead to anything. The person may just
It just may be a mild cognitive impairment, and that's all that you have, not progressing into anything more involved.
But again, and we will keep stressing this, because what we found when we were working together is that people who do have a mild cognitive impairment or any kind of progressive impairment of their cognitive skills really are at risk. And you need to have supports and environmental modifications in place to protect them. So we're going to look at the causes of dementia. It can be caused by various conditions that damage brain cells. And we've talked about a few. I'm going to go over them now. Again, Lyme disease, Alzheimer's disease, Parkinson's disease, Huntington's disease, high fevers, and systemic lupus can all contribute to the onset of dementia. And Linda, you want to talk about the more medical ones?
Disruption of oxygen flow to the brain can be due to heart disease, strokes or CVAs, smoking, chronic poor nutrition and dehydration, metabolic disorders, liver or kidney diseases, drug and alcohol abuse, traumatic brain injuries, even STDs and AIDS have led to dementias, exposure to environmental and industrial toxins.
Okay, we're going to spend some time on Alzheimer's disease because this is the most common form of dementia. And as we've mentioned, Alzheimer's disease is irreversible and it's progressive. It usually evolves over the course of about 10 to 15 years. About 10% of cases of Alzheimer's disease are considered to be hereditary. It's called familial Alzheimer's disease. But that leaves about 90% where there's no history of any kind of Alzheimer's disease in the person's family. The onset is often not noticeable without medical testing, such as a CAT scan or a PET scan. And these are not usually done in the early stages because there's no obvious indications that the person is struggling cognitively. So we're going to look at each of these stages in greater detail. And what we're reviewing here is the things to be alert to in working with people with intellectual and developmental disabilities, because in the early stages in particular, the changes are extremely subtle. So this is just a graphic that depicts the kind of progressive and irreversible process that Alzheimer's disease follows. In the beginning, you know, the person is functioning well. For somebody with Down syndrome, this would be around age 30. There would probably be no impairment. This would be the ideal time to get a baseline. Then there may be a very mild cognitive decline. When we talk about that, you'll see that this is really something that's not easily noticeable. Then mild cognitive decline and moving right through. Usually Alzheimer's is diagnosed at the point where the person has a moderate cognitive decline, and then in late stage Alzheimer's when we see just disintegration of most brain functioning, you know, seizures and difficulty with swallowing and so forth.
Okay, this is an interesting view of the brain changes that are seen during a PET scan. You'll notice that the, well, it's on my left. I don't know, how is this being viewed?
It's probably,
Okay.
probably on your left.
Okay.
It's the brain with all the different colors.
Okay. The brain with the many different colors, that's the red is the amyloid protein deposits, and this is what's, you know, happens in Alzheimer's. You'll see the varying other colors, the yellows, the lighter blues. These colors are like the beginnings of amyloid deposits, whereas the red is deposits that have caused damage. And the ideal brain, of course, the normal brain, is the one on the right that's totally blue. And it's just interesting to see what someone would see on a PET scan.
And you can also see that before we have PET scans, it was probably even more challenging to diagnose Alzheimer's.
Okay, this first stage of Alzheimer's is where there's no impairment noted, but it's an apparent normal functioning, and that's the key word, is apparent. You're not going to notice that there's a change, but there's little subtle things that are happening that aren't apparent to the caretaker or the family member, or even the person experiencing that. Memory loss may exist, but it's not evident in testing by a healthcare professional. No impairment is noticed by persons, friends, or family. Nothing wrong, but changes being subtle, things are occurring, but they are not obvious enough that a healthcare professional would notice them.
So at this point, if you were to do a PET scan, would you see some of the red stuff?
You probably would see some of the yellow discoloration, probably not the red. Yellow is the beginning.
Okay, in the second stage, we see some mild cognitive decline. There's some loss or forgetting of familiar names. Senior moments become common, and they're really like kind of like little glitches. A lot of us talk about senior moments. Maybe we have dementia already, but maybe not, probably not. A person might forget where they left a common object, like their keys or their glasses, something that they would not normally forget. And again, as with stage 1, this is often not diagnosed or noted. People think it's normal to be forgetful, particularly when someone is a little bit older. If you did do a PET scan, it would show some changes, probably some brain atrophy.
Brain atrophy you see on a scan, on a CAT scan.
On a CAT scan? So you wouldn't see that on a PET scan?
Well, what you're measuring on the PET scan is the protein deposit.
Okay, see, this is why I always work with Linda, because she knows the medical stuff, and I know the caregiver and the social work stuff. Thank you. So you would do a CAT scan, and that would show some atrophy, but it wouldn't indicate that you had to do anything, you know. And even with a brain scan, with a CAT scan, you would not necessarily have a diagnosis.
And some atrophy also occurs through the normal aging process. So these are early stages, it's early testing. I'm probably not even going to have someone recommend the testing at this point to see what's going on, because things are so subtle.
And with IDDD, would somebody also have some, like a smaller brain or some brain atrophy as part of the developmental disability?
Down syndrome, you already have a smaller brain. So yeah, there are some differences there to begin with. That's why we go back to baseline. Okay, a mild cognitive decline. Friends and family start to notice some differences. The person experiences a decreased ability to remember names. Person has an impaired retention when reading. Person frequently loses objects. The person experiences diminished ability to plan or multitask. As you're beginning to notice the changes, like common names, you're going, oh, can you have what's his name come over? But this is his son he's talking about. Or someone that is a very familiar person, but all of a sudden that name just kind of glitches out. This is when you would see someone who's sitting there reading a book and they're not aware that they just read the same page twice. medical diagnosis is possible at this point. It would be a very early diagnosis of Alzheimer's if it was made, even at this point. Obvious memory loss, reduced memory of personal history, and a physician may be more likely to recognize that something's not quite right or a little off with the patient that they're treating.
Particularly if the physician has working knowledge of the person,
right,
and has seen him over the long term.
Right.
And again, we talk a lot about forming a network of healthcare providers who know people with IDDD over the long haul, who take care of them over the course of a number of years. And that's why this is so valuable, so that when there is a change, a subtle change, the doctor is going to be able to notice that. Okay, in stage 4, you'll see a moderate cognitive decline, and again, this may be a point where early Alzheimer's disease is diagnosed by a medical professional. The doctor can see that the person really doesn't have a good memory of his personal history, may not be able to remember recent events. They can't balance a checkbook. They can't perform any of the kind of higher intellectual functionings. They become impaired. And communication skills start to really decline at this point. The person may have been a very social person with a lot of friends, and now the person becomes more withdrawn. This might be something that you would very commonly see with somebody with IDDD, maybe before you would notice other changes, because, maybe the person was never able to do complex math. Maybe the person never was able to manage his own money. But you know that person used to be really sociable and have a lot of friends, and you notice that this is changing very gradually.
Moderately severe cognitive decline is stage 5. It's a mid-stage of Alzheimer's disease. The person is experiencing major memory gaps. They start to need assistance with their activities of daily living, the bathing, the toileting. They're mixed up about how to wash themselves, to brush their teeth. The basic things that they always did, they now need assistance with. The person is disoriented around time and place. They do still know their name, but the confusion is more about time and place. Persons are able to recall some family members' names, but not consistently.
Stage 6 is severe cognitive decline. You start seeing some major deficits in independent functioning. There may be some loss of bowel and bladder control, in which case you would address that by developing a bladder and bowel program, maybe a trip schedule. The person is going to need some hands-on daily care. This is also where what's called sundowner syndrome may emerge. You'll see some increased agitation and anxiety and restlessness in the early evening, and even through the night. People often have trouble getting to sleep, or they can't stay asleep. There's some wandering that goes on. The person may get lost. At this point, when you're working with the person, you want to really make sure that you have a lot of safety features built into the residential situation.
In stage 7, it's a very severe cognitive decline. This is your approaching late-stage Alzheimer's disease. A person has lost the ability to respond to his or her environment. He or she no longer is able to generate recognizable speech. The person may be incontinent. The person is no longer able to take a walk without assistance. He or she may even lose their ability to smile. A person may display abnormal reflexes and muscle rigidity. They may have an impaired swallowing, and they may have seizures developing. It's a time when you start having unrecognizable speech and such, many needs for care. Hospice will also can be involved. They can put some supports in the home. Office of Aging in your communities can also be involved. They have some supports that they can put into the home. The bigger risk you're going to see is aspiration pneumonia because of the swallowing deficits. And sometimes that ends up being the actual cause of death at this stage, is an aspiration pneumonia or swallowing problem.
So at this point, we're going to move on to to talking about other things. At the end of the section, we are going to have time for questions, but if you have questions over this piece, it's fine to start typing them in now. I know this is a lot of information that we're providing, and you know, we are able to talk about it in greater detail if there are specific areas that you have an interest in or that we didn't make clear. Okay, we're going to talk about the Global Deterioration Scale, and this is a worksheet that's designed to identify the stages of Alzheimer's disease. It's designed for use of people who are not challenged with IDDD. We're including it here because if you're working with somebody and you know that person very well, you're going to be able to kind of tease out the skills that that person has already had and the skills that that person is losing, particularly if you have a reliable baseline that you're testing against. Linda's going to review the specific scale in detail, and you should also have a PDF copy of it that was included with the presentation. And again, if you don't download it now, you have the opportunity to download it from Resources for Integrated Care, and that web address is right at the bottom of each slide.
And when you're looking at the Global Deterioration Scale, it's just a tool to use as a caretaker or involved with someone with an increasing amount of dementia. And just as we reviewed this, the different stages of Alzheimer's, stage 1 through 7, this is like a nice little tool that it shows you what kind of care setting would you expect that person to be able to live in based on the stage of Alzheimer's that they're at. It's a useful tool in someone with mild intellectual disability. Someone with the moderate to the severe range, that's where baselines come in to be very necessary, because unless you know what that person was capable of, there's no way to evaluate them based on a standard assessment tool. Whereas someone with mild intellectual disability, they may fit into these areas. As you go through, you'll see in the stage 1, they can live in an independent setting. When you hit stage 2, you're starting to see some mild memory loss, but you don't have a function deficit. So this person, if they were living in the community, they could still live in the community in an independent setting or in the setting that's normal to them. On stage 3, you have a mild cognitive decline. On this level, you can still manage in an independent setting because there's some denials that there's something wrong, but the person is still basically capable of functioning on their own. Some memory loss, some confusion, sporadically misplace an object, misplace their keys, can't find their eyeglasses. I mean, these are kind of things that you may see, but you can still live in an independent setting at that point. With early dementia, there's clear-cut deficits that on a clinical interview you can see those deficits. Handling finances, handling traveling, handling going to a job, handling your daily activities of living, your bathing and feeding. These are all things that you may not be able to do without assistance from a caregiver. So the setting that that person is living in now starts to become more restrictive. Moderate dementia, you can no longer survive without some assistance. At home with a live-in family member, reside in a senior residence, reside in a supportive home of some kind, because there's substantial deficits that are occurring where you could not be living on your own. There's some disorientation as to the date and day of week, season, or place. They require may require some assistance for toileting, may not require assistance for toileting, but it's starting to be something where you may have to prompt someone to do something. Prompt them to start with your face. Wash your face first, then wash your chest, and work your way down your body, because that may get confused along the way, but they're still able to do some things themselves. Moderately severe dementia, remembering names of people that are familiar to you are no longer familiar. You're looking around, you can't remember the names of the people that you lived and worked with on a daily basis. Largely unaware of recent experiences and events in their lives. They will definitely require assistance with ADLs and may also be incontinent of urine. Behavioral and psychological symptoms are starting to be prevalent, such as delusions, repetitive behaviors, agitation, pacing. the living setting would have to be a much more complex care facility, possibly a skilled nursing facility. Severe dementia, verbal abilities will be lost. Incontinence is a definite. They need assistance with feeding. They have possibly lost their ability to walk. And again, you'd have to be in a complex care setting or a skilled nursing setting.
So, I think working with people that are on your caseload, this is not something that you can use to diagnose the onset of dementia, but it's something that can inform your practice and your planning. And, you can also use this depending on your relationship with the family. I think it's kind of intimidating to just present it to a family member, but you can also use some of the information in here to review with the family member what to be aware of if somebody is beginning to show signs of early Alzheimer's or dementia.
I mean, it's a tool to use to determine what's the right setting for this person to live in at this point of the stage of development.
And I think also looking ahead, I mean, someone who may have been very independent, may have had their own apartment, is probably within the course of a number of years, because it is a slow progression in most cases, they're going to probably need to be in a much more structured and supervised setting, maybe a group home or whatever. And we're going to talk a little bit about this as we go on, but you might want to start getting some feedback from the person in terms of what their goals are for themselves as they grow older, so that you have an idea of what that person would choose for himself. So at this point, if you have any questions, you can type them in, and I don't know if we have any.
We do have one. We have a question from Jackie. And Jackie writes, I was taught the only way to confirm Alzheimer's is with autopsy. Is this no longer the case since PET scans seem to be able to see the abnormal deposits?
Yes, PET scan's going to do the diagnosis.
So, and I think that's another issue that comes up a lot, that as medical science evolves around issues of Alzheimer's and other dementias, and there's more technology available, we're identifying it at an earlier stage, and we're able to plan for it better as practitioners. So people are living longer. We're seeing more cases of dementia, but I think we have the opportunity to be better prepared for it. Any other questions? So I think we're going to go on. Please feel free to continue to type in questions about this section that we just finished, or if questions come up as we go forward. It doesn't disrupt the presentation, and we'll address them when we get to the next break for questions. Okay, we're going to talk about dementia and Down syndrome, because people with Down syndrome, as we said, are at particular risk and have particular vulnerabilities for developing Alzheimer's disease. And we're going to look at some of those in greater detail.
The risk factors for Alzheimer's disease in people with Down syndrome. People with Down syndrome are living longer, as we mentioned before, so that risk of developing Alzheimer's is there for a larger percentage of people with Down syndrome. It doesn't mean that everyone with a diagnosis of Down syndrome is going to develop Alzheimer's disease, but it does mean that possibility of that occurring increases. Pre-existing genetic susceptibility, with the IBR study, there was a connection found between Alzheimer's and Down syndrome. Doesn't mean that they absolutely, like I said, are going to go on to develop Alzheimer's, but there is a possible genetic susceptibility to developing Alzheimer's in Down syndrome.
And if I could just interrupt you,
Sure.
The IBR study with the Institute for Behavioral Research,
yes.
That's a research organization that's part of New York State Office for People with Mental or People with Developmental Disabilities, and
yes.
You were actually somebody who was a reporter in that study.
I was part of the study with people on my caseload with Down syndrome.
And I don't know if you can access that online, but I think it came up with some very interesting results. And I think if you go to New York State, opwdd.gov.ny.gov, you should be able to access some of those results. I'm sorry to interrupt.
That's all right. And the IBR study, just being Jill did mention it, it was over a long process of years. I had people on my caseload that were part of that IBR study. We had received consent from their families to allow them to be a part of that study. And it was every 3 months. someone came and we had a criteria we were looking at that involved lab tests and capabilities of that person that was screened and recorded every 3 months to see what kind of progression, if that person even progressed to Alzheimer's. Some did not, even though they were in the Down study. The other problem with Downs that predisposes to Alzheimer or increases the risk, women with Down syndrome have a higher risk of developing Alzheimer's because the estrogen deficiency and earlier menopause puts them at a higher risk at an earlier age than a male with Down syndrome. Some more factors with Alzheimer's and Downs. The Down syndrome is specific brain. It says brain development that's a decreased brain weight and size, a reduced frontal lobe volume, and a decreased dendrite branching during fetal development, which all are predisposing that person to the possibility of developing Alzheimer. The APOE gene located on chromosome 19, and there was a link connected to cholesterol and lipid metabolism on that gene. IBR, the Institute of Behavioral Research study, provides evidence that lowering cholesterol levels may reduce the risk of early development of Alzheimer's disease. It doesn't mean it's not going to happen. It doesn't save you from having Alzheimer's if you were predisposed to be someone that would have it. But they found a connection between people with elevated cholesterol put on statins for some reason. If they did go on to develop Alzheimer's, it was at a later date.
So I'll do this one.
Oh.
Neuropathology in people with Down syndrome. People with Down syndrome, as Linda has been saying, are predisposed to developing it. They already have some issues in the way their brains have developed. They have the deposits of the plaques and the tangles that are also characteristic of Alzheimer's disease. Changes can begin as early as 35 to 40, and a PET scan will reveal these. And we saw that picture where the person will begin to develop those
Protein deposits.
Those protein deposits and the red and the yellows in the PET scan. And actually, at the bottom of this slide, you'll see the link to get to the OPWDD Institute for Basic Research, and you can look at this study that Linda participated in, and it's pretty interesting. Some of the considerations that you want to take into account when you're working with somebody who has Down syndrome is that they do have a tendency towards premature aging. So even if they don't develop Alzheimer's, they're going to age at a faster rate than someone who doesn't have Down syndrome. Some people will have developed symptoms as early as their 40s. I've seen people who were about 40, and by the time they were 40 and a half, they had a pretty accelerated rate of Alzheimer's. That was obvious. Again, we can't use standard tests to diagnose dementia conclusively in some people.
In some people with Down
syndrome, because they already have cognitive impairments that are associated with the IDD and the Down syndrome. So cognitive abilities vary very individually, and whenever you're doing an assessment, you can use an assessment that was designed for someone who did not have an intellectual disability, but you have to be aware of what the person's baseline was and take that into account in working with them. And when you work with a physician who's going to assess the person, it's important for that physician to be aware of what that person's baseline was so that they're not diagnosing a dementia when there actually may not be one. Okay. The diagnosis of dementia in someone with Down syndrome requires a change in their status over a period of about 6 months. And the change could be in cognitive functioning and behavioral functioning. Many times, and we're going to discuss this as well further along, you don't see a cognitive decline initially. The first thing that may be noticeable is the way the person's behaving. There may be a real change, as I said, in their social interactions. The person may also become very agitated, may become sort of irritable or even aggressive. In doing assessments, it's important to involve both a caregiver or the family member, someone who knows that individual well. You're going to use reports and observations of how the individual was. Initially, you want some concrete information about how the person used to behave, and use that to compare it to what you're seeing at this point. And that's why the baseline is so important in working with somebody with an intellectual disability, and in particular, somebody with Down syndrome.
There's been some people working with developing a mini mental exam for more specific to Down. The DSMSE test includes recognition of simple designs, word object matching, and serial naming of objects. It was developed by Dr. Haxby and Dr. Silverman. It's more specific to someone that would be functioning on the level of some of the Down syndrome people that you have on your caseload, so that you have to know the baseline, but at least if you have that baseline, you can kind of fit the person to the test so that you can have a criteria that's measurable and monitored for over time, because that's what you're really looking at. A DSM-SE test is what you're going to be repeating that every 3 months or or annually based on what's going on in that person's life, so that you have a criteria that is workable and usable for that person's functioning level. There's also a TSI, which is a test for severe impairment. This test for cognitive function in people with severe impairments in intellectual impairments as well as motor impairments. It was developed in 1992 by Albert and Cohen. Informant-based assessments or questionnaires that are completed by caretakers are also a useful way to measure social and cognitive functioning that might suggest a dementia. Baselines for a person with IDDD or Down syndrome should be, you should be able to look at what things did they know before. What objects would they remember or relate to? What pictures could you show someone that they would recognize what it is? Set up a criteria from before dementia develops. So that does that person know how to tell time? Does that person work in a job and can carry out multi-task functions, multi-step functions? Can they write their name? Do they have some reading and writing skills on some limited basis? Make that stuff available from caretaker to caretaker, from doctor to doctor, so they know when something is changing. I had a person on my caseload, Mike. He was in the IVR study, and Mike was able to write his name, but only the first letters of his name. He could write the M-I-K-E. And he could recognize if someone else wrote his entire name. He could pick it out from a piece of paper that you wrote it on. He would know right away that was his name. And, so one of the tests that we did in the IVR study every 3 months when people came to interview both myself and Mike was have him write his name. And at some point in time, Mike started losing that ability. He could only make the M, or he could only make some of the letters, or he put them in a backwards order. He no longer was able to carry out that task, which was something that he did all the time prior to that. He had a way of telling time, but his way of telling time was by meal time. He didn't know how to take, so you couldn't do a standard test of the clock, where you have someone fill in the numbers and put the hands by a certain time. He never had that capability, so you couldn't use that as a useful test for him. But what you could do is you could test him in terms of, was it the next meal today going to be lunch or dinner or breakfast, because he knew what time of day it was based on meals. He also he knew exactly when mealtime was when he got home. He was particularly fond of pizza. He knew Friday was the end of the work week. He knew when he went home on a Friday that was pizza night in his house. As that's the night that he didn't go up to his room and kind of hang out there till they called you for dinner. He actually parked himself at the table and stayed there until the pizza was delivered, because he knew that was the night it was coming. When we did object testing with him, we picked objects that he was interested in, like a picture of pizza or colors or objects that he recognized. And we set those criteria up ahead of time, and then we monitor him every 3 months and test to see what is still able to do.
So we're going to look at some particular tests and how they're used to diagnose dementia. We're going to be looking at both standard assessment tools as well as those that have been developed more recently, which are designed specifically to assess people with an intellectual disability. There are very few assessment tools right now that are designed specifically for people with ID and DD, and we'll examine why that is as well.
Okay, standard assessments for dementia are diagnostic criteria that specify decline in memory and in at least one of the following cognitive abilities: the ability to generate coherent speech, understand the spoken or written language, ability to identify objects, ability to execute motor functions, ability to think abstractly, carry out complex tasks, and make sound judgments. The criteria used to assess dementia is based on pre-existing ability to communicate, to have cognitive and memory skills, to have basic math skills. Individuals with ID/DD sometimes didn't have those skills to begin with, so you have to start at the point that they already are at and have that baseline to look at so that you can test from that point on.
Dementia is often experienced differently for people with intellectual and developmental disabilities. As we noted earlier, people with Down syndrome often experience dementia at an earlier age. It maybe is more rapid in the decline with a briefer duration between diagnosis and death. In working with somebody with ID/DD, you want to tease out what's the result of the intellectual disability and what's actually a cognitive change. You want to be particularly alert for behavior changes. These are often the first indicator. And as we've been saying, diagnosis is often extremely complicated because individuals may not have had opportunities or abilities prior to the onset of cognitive decline. Many people who are living in situations where they've had a history of having someone provide care for them may not have had opportunities to develop a lot of independence, particularly in terms of making judgments on their own or being independent intellectually. And it's very important to be able to start developing support so that person can age in place as cognitive issues begin to decline. If there's a rapid onset and progression of dementia, you may not have a lot of time to provide these supports, so you want to have them in mind. You want to have a plan in place if you're working for someone who's at risk for developing dementia. So people who have ID/DD may not be skilled or accurate self-reporters because of their limited functional and expressive language skills. They may not know the names of common objects. Melinda was talking about the person on her caseload, Mike. He was really good at naming the names of foods that he liked to eat, but he would not have been able to identify, for example, computer. When you see impairments, when you're evaluating for impairments in abstract reasoning and judgment, these may not have ever existed, so they may not be indicative of cognitive decline. And individuals with ID/DD often have diminished or impaired functional skills in independent living because they've never learned those skills or because they didn't have the capacity to learn them as a result of the disability.
Existing impairments, like Jill was saying, must be considered in a dementia diagnosis. Most standard screening tools have limited value. Diagnosis of dementia for people in general population is based on assessment of memory loss or cognition decline. Initial efforts underway to develop assessments and screening tools are more specific to ID/DD population. But so we keep going back to the same thing, the baseline. Have that baseline charted, recorded somewhere, and every time you're going to a doctor or looking at assessing this person, you have that baseline to go back to on, is there a deviation from that? Baselines of capabilities prior to possible symptoms of dementia remains the best tool for monitoring someone with ID/DD and dementia.
So as we said, dementia diagnosis of people with ID/DD is based on the process of recognizing a change or decline from a prior level of functioning. Using a baseline, caregivers are going to be able to report how the person is changing from a previous level. You want to work with the caregivers and also yourself to be alert to changes in someone's behavior. Someone who used to be very cooperative and easygoing may suddenly become agitated, even aggressive. As I mentioned earlier, with somebody with an ID/DD, particularly someone with Down syndrome, change in behavior is often the first sign that something is going on in terms of a cognitive decline. Changes in personality and behavior are frequently the first signs that you're going to see. Frequent and early screening, including consistently repeating the baseline, is essential.
Standard screening tools, like we said, are inconclusive for adults with ID and Down syndrome. Because you have a varied level of cognitive function in someone with ID, DD, or Downs. There's a decline in individuals with ID Downs, which can be present in many different ways. Like Jill said, changes in cognition are often accompanied by changes in behavior. It's difficult to establish a cutoff score on a standard test. That would be, because of so many differences in cognitive and motor functioning. Aging caregivers are also not always a reliable reporter of information.
So what can you do? We're going to look at some proactive responses and planning. The first one is, of course, baseline of the person's functioning and abilities at an early age, and for people with Down syndrome, what's recommended is age 30. We continue to stress getting a comprehensive baseline because it is the most valuable tool you're going to have in diagnosing and planning for someone with Alzheimer's or another dementia. The baseline should include the way the person interacts, what he or she is able to do in terms of self-care, a video recording of that person talking about himself and engaging in various common tasks is often the most accurate and valuable tool you can have. And this will serve to jog the memory of caregivers. Sometimes individuals who are in congregate care settings have multiple caregivers. Staff tend to change, or the person may change living situations. And having that baseline tool as something, and as I said, as a video, is something that can follow the person no matter where he is, or can be used by caregivers who are meeting the person for the first time, maybe 5 or 6 years after the original baseline was done. And someone who's looking at that video recording with new eyes may notice subtle changes that other people who see the person every day may not pick up on. Person-centered planning is particularly important, both with caregivers and the individual, so that you can begin to develop a network of supports that will be most helpful to the person as he ages. You want to develop some collaborative networks with healthcare providers, particularly physicians, so that they have an awareness of who the person is, and they're more likely and more capable of picking up subtle changes during annual wellness visits.
As we said all along, why document a baseline is the most important tool in assessing an individual with IDDD. Often it is difficult to assess individuals with IDDD reliably due to lifelong histories of impaired abilities, particularly in communication and functional skills. Those standard assessment tools are geared towards a person's ability to self-report, and in some cases, in someone with IDDD, they're not able to self-report. Their communication skills are more limited. So tests have to be kind of geared to what their capabilities are. And as Jill mentioned, video recordings are a useful tool.
So the baseline can also be used to identify new changes in behavior. It distinguishes how the person used to behave and how she's functioning now. You can back up cognitive tests with a review of the person's functioning and what you want to look at when working with somebody with IDDD or Down syndrome is the activities of daily living. Is that person able to dress themselves as neatly and independently as he could do it a year ago? Social relationships. Did that person always have a lot of friends and now seems to have fewer friends, or seems to be less interested in spending time with them? Did that person used to enjoy going to movies and watching a whole movie and is now maybe losing interest after a couple of minutes of watching something? How does that person engage in a daily routine? Is the routine something that the person is able to engage in very readily and very functionally, or is it beginning to struggle with it, having trouble getting up, having trouble remembering what time of day it is? Is it time for breakfast? Is it time for lunch? What about behavior changes? Is the person confused when they used to be really, really sharp and saying, well, now we're going to do this, and you promised a movie for this Saturday? Or are they confused about the day of the week and what activities have been planned? Is that person resistive when they used to be cooperative? If you're saying it's time to get dressed for work, is that person becoming very non-compliant or arguing with you about what time it is? And again, this is something new. If the person was always really independent and has their own way of functioning with a routine and always argued about the routine, then that would not be a sign you would necessarily be concerned about. But if this is something brand new, if the person was always kind of hurting everybody else in that setting around and saying, come on, it's time to get going, and now they're not doing that anymore, that would be a cause for concern.
Okay, use as many tools as you need to assure a reliable assessment. Some of the tools that you're using are caretaker information. So caretakers need to also be educated on what to look for. What is an indication that there's dementia developing? What kinds of symptoms should they be reporting? What kinds of concerns should they have about changes? What becomes a reportable change? What's something that they should just expect as normal behavior? Develop a network of providers who have experience in assessments of individuals with IDDD and Down syndrome. Share the baseline information with them and help them to distinguish between loss of previous abilities versus the person's baseline. Be proactive, like I said, with family and caregivers, and educate in terms of what they need to be looking for. You need to facilitate regular, ongoing screenings for dementia at that annual physical. If that person is on meds where they're seeing a psychiatrist every 3 months for med monitoring, that one of the things they're also looking at is changes in behavior and documenting back to the baseline.
Okay, the NTG, Early Detection Screen for Dementia, was developed by the National Task Force Group in 2010. And as I mentioned, there have not been very many, if any, tools that are designed specifically for use with somebody who has an intellectual disability. The development of such a tool was one of the goals that the task force had for itself. And this document is also available as a PDF in your packet. You can download it. If you don't have it now, you can also download it after the presentation at Resources for Integrated Care website. And again, that's at the bottom of the slide. This screen was developed so that it could be used as part of the person's annual wellness visit. As a caregiver, you might want to go over it with the individual before the wellness visit and then bring issues that you've noticed that you think are of concern to the attention of the physician. It's designed so that caregivers and family members can use it very comfortably, and it won't really provide a diagnosis because it's not being used by a physician necessarily, but it's going to start to identify some of the common signs of early dementia. Perhaps the most important part of this is that it's going to keep the conversation going or maybe even initiate a conversation. And it helps caregivers and family members to be aware of what early signs of cognitive decline look like and what they should be watching for. So I didn't print this into the slides, but if you have downloaded your copy, I'm going to go over some of the things that are noted in this. And it's important to think about these. These can also be used if you're working with family members or caregivers in an educational capacity to bring to their attention some of the things that you're going to want them to be watching for. Again, particularly if they're working with somebody who has Down syndrome and is in that age group when we're going to start seeing some early signs of decline. Probably the first thing to look for in this scale is the activities of daily living. And the way this scale is designed, it talks about what the baseline for that person is, what's always been the case, has the person always needed help with washing or bathing, or is this something that's declining and is something new. Language and communication, did the person always have trouble initiating a conversation, or is this something that is a a new symptom in the past year. Maybe the person has never been a verbal individual, and so communication, verbal conversations does not really apply. Change in the sleep and wake patterns, and this would probably be one of the earlier signs that you might see, Linda, right,
Yes.
with a behavior change in sleeping. Is the person sleeping more? Well, if this has always been the case, the person has always been, you know, not wanting to get out of bed in the morning and go to work, okay, you're going to note that. But if, you know, recently it seems a little worse, you have the opportunity to indicate that too. Ambulation, is the person not confident walking over small cracks or lines on the ground? Maybe they were always one of those people who avoided the cracks in the sidewalk, or maybe now they're having a vision decline and they may be reluctant to do that. So again, I encourage you to download this and look at it. It's good to incorporate it into working with people. Keep it in the file. You can use this as a tool to develop your initial baseline, particularly in conjunction with a video recording of the individual, and it's something that you would want to repeat on a regular basis so that you can pick up any of the subtle changes. So another evaluation and assessment tool is the Down Syndrome Dementia Questionnaire. And this was developed in, and I have at the bottom of the slide, I have the web link, and again, you can download this at Resources for Integrated Care. This was developed by an organization in Kansas City, the Down Syndrome Guild of Kansas City. And it also provides information primarily for parents and caregivers, and it offers some good resources to you as practitioners in teaching caregivers about what to be aware of in working with an individual who's at risk for developing a dementia. Again, this isn't a diagnostic tool, but it's definitely an important resource. Just like the previous document, it compares what the person could do as a baseline, and then it targets what things are changing. Looks at ADLs. It looks at, one of the interesting things in this is it can tell something to those people who didn't go on a trip. It can describe, you know, the person's able to describe something that happened, and that's kind of getting at those higher level cognitive functioning. Talks about, does the person take an interest in what's going on around the house? Is the person still engaged in that daily routine? It also identifies some behavior changes. Does the person get angry easily? And again, it teases out, was the person always somebody who might have been, you know, easy to agitate, you know, easy to get angry if somebody was bothering them, or is this something that's happening for the first time and perhaps more frequently? So, not always dementia, though.
Yes. There's other things that have a dementia-like component to them and are being caused by something that you can do something about, such as an illness or a condition that's correctable. Acute or chronic illness, pain, seizure disorders, sometimes how someone exhibits the problem may look like a dementia. Life changes such as separation, bereavement, moving to a new residence may change someone's behavior, a way of handling a situation that looks like a dementia, but it's not. There's a actual reason why that person is behaving differently. Mental illness, particularly depression, is sometimes confused with dementia. Nutritional deficits. Now, these are things we can fix. You know, B12 and folate deficiencies, also common in Down syndrome, can be corrected. We can supplement someone. Otherwise, you can have like a behavior change that is related to deficiency, not a dementia. Urinary tract infections. Sometimes people are uncomfortable. They start acting out, or they have a change in mental status, but it's actually a urinary tract infection. It's treated. They go back to their normal state of being rather than an altered mental status. Upper respiratory infections, pneumonias. Someone is sick, they're uncomfortable, you may see a change in mental status, but it's not dementia. Vision and hearing loss, like Joel was mentioning before. I mean, that person that normally was able to walk down the steps, now they have, they're aging and they have a peripheral vision loss. They can't see the depth distances. and they're afraid all of a sudden to go down the steps. It's not dementia. It's because they visually can't see the changes in the depth of each step. Hypothyroidism is also another treatable medical condition that may have an altered mental status connected to it, and you provide the Synthroid, provide a proper treatment, that person has that problem corrected. Sleep apneas, reactions to medications, these are all things that may look like a dementia, but they're actually not.
And I think what's important in this is that, and we've talked about this earlier in this presentation, people with intellectual disabilities traditionally are not good self-reporters. I mean, that may be the result of historically, in the more recent past, probably not currently, they didn't have the opportunity to be listened to, so they kind of stopped reporting about what they felt or thought or were experiencing. But even so, if someone has some communication deficits or some cognitive deficits in terms of abstract reasoning, they really may not be likely to say, I'm not going down the stairs because I can't see them, or I need to have my glasses prescription changed. And that may not be because of a dementia. It may be because they just don't have the skills to communicate. So as practitioners, you need to be aware of how that person typically communicates, and if you see a change, you want to consider dementia, but you also want to consider that there may be other factors involved, and it's not always dementia. So some of the changes that caregivers should be watching for are those subtle changes that are easy to miss. Again, that person who was in everybody's business or very socially engaged now wants to spend more time alone, or may even get into arguments with people that they previously got along with really well. People who used to take great pride in their appearance may suddenly be not as careful. They may appear disheveled. They may not be combing their hair or tucking in their shirts. It's a subtle change. And it could be related to dementia. It could be related to depression or another issue. Seizures may occur, and this is particularly something to be concerned about if there's no previous history of a seizure. It's another reason to have a baseline and also to share with new caregivers what that person was like before and what that person's history was. And if somebody is new to you, it's important to be proactive and to get the history. If the history isn't available when you first meet the person, you might want to reach out to the family or to other people who know that person well and have a documented history available. You may see gradual but increasing confusion. Again, somebody who's not close to the person may not recognize that. They may dismiss it as being part of the disability when actually it's a change in the person's ability to function. Communication and awareness of that baseline is really key. And when we talk about communication, it's sharing across shifts if the person is in a congregate care situation, sharing among caregivers, initiating discussions proactively with family members and with healthcare professionals who may not see that person every day. I know we talk a lot about caregivers being given the tools to report and participate in assessments, but I think it's also important to recognize that caregivers may not always be objective. If they see the person every day, they may not notice subtle changes. We all know that when we're on diets, the people who see us every day never notice that we lost half a pound yesterday. And it's the same thing with dementia. If you don't see a person for a while, you'd be more likely to notice a change. And that's a good reason to keep family members involved in the conversation about dementia. Family members who have been actively involved with the individual may be aging themselves, and they may also be experiencing dementia themselves. So they may not be reliable reporters because they may not be able to notice that change themselves. And there's also the possibility that denial comes into the picture. Family members, who have watched an individual struggle to attain skills and work so hard at learning to do things that people without intellectual disabilities learn very easily, may have a really hard time watching that person lose those skills that were so hard to attain. They may think, if I don't recognize it, if I don't talk about it, this is going to go away.
And as a health professional, it's important you assess your caregivers. Remember, we had a few caregivers that I did a visit to the home, and they asked me they brought out a med box that not only had the meds of the person they were taking care of, they had their meds, and then mixed amongst all those meds was meds for Alzheimer's, Aricept, et cetera. And they were, all of a sudden we started realizing that this was a person that was no longer really capable of taking care of the person in their care. And we started looking at alternative situations for the people in that home.
And you know, that actually does happen probably more frequently than we realize, where a caregiver has always cared for the developmentally disabled family member, and as the caregiver ages and develops some dementia themselves, the person with the intellectual development or developmental disability is providing some of the care
For the
person. And there have been some situations where it's been really stressful for that individual to see a parent or a sibling decline when they used to be a reliable person. So, you know, as I mentioned, individuals who are living in congregate care may experience multiple caregivers over the course of weeks or months. You want to assure that caregivers who provide information know that person well, that they're not just speaking from, you know, a week's worth of knowledge of the person, or the caregiver, you know, works on the night shift and never really sees the person functioning during the day, so they don't have really a reliable report of what that person's abilities are. You want to be proactive in teasing out from the caregiver what their knowledge and familiarity with the person is. A natural flow in many congregate care settings is to respond almost automatically to the needs that a person indicates. And caregivers may not be aware that the person's needs are actually increasing and that they're providing gradually more and more levels of support. So you want to try to tease out if the person is gradually requiring more supports in his or her daily life. And again, the tools that we provided as PDFs and that we discussed are really useful in talking to caregivers. You know, you want to maybe tease out, you know, some of the specific areas that are identified on those tools. You want to avoid missing a diagnosis of dementia or not diagnosing that person with a dementia until you're seeing some advanced symptoms. Because remember, not all dementias are progressive. Some may be, like vascular dementia, they may be treatable. They may not be reversible, but you can still stop the progression. So it's important to be alert and aware and diagnose as early as possible.
As Jill mentioned before also, opportunities for choice and decision-making in a controlled setting are limited because of the environment that person is living in. So to evaluate someone on their memory or their judgment capability in a home where they didn't have very many opportunities to make their own choices, it is difficult to make that assessment. Individuals with IDDD have lived in sheltered environments with few intellectual demands. They're given a routine, they're directed. How do you learn how to make choice if you're in a situation where you're not given the opportunity to make many of those choices? It puts at risk a development of a more advanced stage of dementia before you actually make a diagnosis. And as Jill said, many dementias can be delayed. The progression can be delayed. So with an early diagnosis, that makes it all more essential. Memory problems are not the first symptom of dementia. For people with Down syndrome, we mentioned this before. What you're going to see is things like personality change, uncooperative behavior, irritability, aggressive behavior, inappropriate actions, giddy silliness. These are all things that, you know, you should be alert to because they may be how a dementia is being expressed. So you want to know what that person's baseline is.
So at this point, we're going to give you the opportunity to ask some questions, and then I think we're going to have a break. Again, I encourage you to type in your questions. You can even be typing them in during the break. We'll check again to see if some questions have been identified. If you want to use the break time to download those PDFs, that may also provide you with some opportunities to ask some questions. So do we have any at this point? Okay, I'm going to go ahead to the break. We're going to do about a 10-minute break. So here in Albany, it's 2:25, so we're going to come back at 2:35, and we'll see you.